Okay, so welcome to the Enhancing Clinical Practice and Outcomes stream at the SNOMED Expo 2021. My name's Ian Green. I'm the clinical engagement lead globally and also the customer relations lead for Europe for SNOMED International, and I'll be moderating today's session. So please use the live Q&A in your AirTouch device to type your questions to the presenter, and all questions will be answered at the conclusion of the presentation. And I'm now pleased to introduce Amanda Steffon from 3M, who'll be presenting today's presentation entitled Evaluation of SNOMED CT for the Identification of Social Determinants of Health Concepts and Value Set Creation. So Amanda, I'll hand over to you, so please proceed.
All right, thank you so much, Ian. I appreciate that. As Ian said, we'll be talking about the identification of social determinants of health and the value set creation. So during this session, participants should better understand the role that SNOMED CT plays in the creation of social determinants of health value sets, be introduced to the application of SNOMED CT's description logic and machine-readable content model, and learn about the challenges that we encountered while creating and curating value sets. Social determinants of health, commonly referred to as SDH, are the non-medical external factors that influence patient health outcomes. The World Health Organization defines SDH as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. This definition is only one of many. As the definition and the conceptualization of SDH continues to evolve, so does the content developed to capture this information through data. As healthcare attempts to address SDH, the use of terminology standards becomes increasingly important for improved interoperability. Each terminology release cycle, we see these standards grow in their ability to capture and encode SDH. Identifying these concepts and grouping of SDH allows for us to translate data in a meaningful way. Our team's goal for this project was to evaluate the feasibility as well as the level of effort needed to create value sets for SDH. The value set creation within our team started by recognizing some of the common categories of SDH. Some of these broad, commonly identified categories include economic stability, healthcare access and quality, neighborhood and environment, social and community context, and education access and quality. These can be further broken down into more specific and granular subsets, as you can see here: food, education, employment, healthcare, housing, income, and transportation. Creating value sets at this level makes them easier to maintain as well as specify their focus. This approach allows for a value set user to be able to combine these into a broader use case as needed. For example, a value set user could create a larger set for economic stability by combining the content of the smaller value sets for housing, income, employment, and transportation. These granular categories were used as a framework for how our team were located and grouped related concepts. Since the intention of our value sets were to capture clinical concepts that could be encoded from an EHR, it was important that our team determine which standard terminology would be used. SNOMED CT is a commonly recognized and clinically comprehensive terminology. Using SNOMED CT allowed for the creation of robust value sets. It gave us the capability to capture the spectrum of a given SDH, including the identification of the patient's problem, the causative factors, assessment of the findings, the assistance provided to the patient, as well as education, referrals for resources, and patient outcome. Recognizing the types of concepts that we wanted to include, we looked at how SNOMED CT's machine-readable content model and description logic could be leveraged to identify and aggregate groups of similar concepts for our use case. SNOMED has created a structure to their clinical terminology that allows for the organization of content and definitions of hierarchical groups and the concepts that are situated within these groups. Using the SNOMED CT browser, we searched for commonly recognized concepts such as food insecurity. We sought to find additional concepts using parent-child relationships, also referred to as supertypes and subtypes, and our team's knowledge of SNOMED CT's hierarchy. The team expanded our keyword search to include terms such as food, hunger, meal, and water. In this search, the team noted that concepts related to food crossed multiple domains and hierarchies within the browser. Here you can see we evaluated the domains of food-related concepts for our value set use case of food. In SNOMED CT, the semantic tags are meant to disambiguate concepts which may be referred to by the same commonly used word or phrase. With a broad overview of these commonly referenced social determinants of health concepts, we noted which semantic tags and domains best identified our use case and the important relationships we needed to take into consideration. In this example, you can see how concepts are grouped by semantic tags provides us with more information about the concept. As you can see on this slide, the team decided on which semantic tags would be valid, including findings, regimen and therapy, assessment scale, procedure, situation, and observable entity. Noting that most SDH concepts for our use cases were primitive, we compared this to common clinical disorders that are defined through their attributes. Myocardial infarction, for example, is defined as infarct that occurs in the myocardium structure of the heart. As you can see, the attributes for this concept are both stated for the concept and inferred from its supertype. If we were to create a value set for this disease, we would be able to leverage these definitional attributes in combination with the concepts hierarchy to identify concepts that are a more specific type of this disease. In contrast, when we looked at an example of an SDH concept, such as the finding of Meals on Wheels, we quickly see that its definitional attributes are limited, broad, and do not fully define this concept. Its attributes are inferred from its supertype, but are not directly stated for this concept. The additional concepts existing within this hierarchy, our team noted, housed multiple findings that were not related to our use case for food. Using some of our preliminary findings, we evaluated the feasibility of creating intentional value sets. These would allow for us to programmatically define and create a given value set. This approach would allow for a user to easily maintain as new terminology is created and released. For this example of myocardial infarction, we would be able to leverage its definitional attributes to programmatically store, aggregate, and maintain a value set for this use case. However, our team quickly identified that this approach would not be able to be used for the SDH value set. SDH concepts do not currently meet the machine-readable content model and do not have enough specific description logic to use this approach. The primitive nature of SDH concepts, hierarchical challenges, and the lack of defining attributes resulted in our team shifting our approach to creating extensional value sets. Though comprehensive value sets were created, this approach led to a manual and subjective method of grouping concepts for our given use cases. This additionally meant that the team could no longer take a programmatic approach to the creation and maintenance, but instead a resource-intensive and manual approach. Because of the challenges terminology faces in defining social concepts, the team encountered some of these same challenges when we created our value sets. As our team worked on this project and created these value sets, we were reminded of the challenges we face in addressing social issues. The complexities that surround any given social issue carries over in the difficulties that terminologies like SNOMED CT faces in their attempts to create and define these at a concept level. Take, for instance, food insecurity. For one person, this might mean that they do not know when their next meal will be. For another person, it may be access to only 1 to 2 meals a day. The causative factors that contribute to a patient experiencing food insecurity varies greatly from lack of income to limited accessibility. Food insecurity is subjective and difficult to define through terminology modeling, but this concept is well understood, and many of us recognize it within our communities or people that we know that are facing it. This project revealed some of the challenges that we faced in the aggregation and creation of SDH value sets and the subjective approaches we use to search for and organize this content. As we look forward, we recognize that many of these challenges will continue to linger. The healthcare community will need to continue to work towards a more congruent definition of SDH. Terminology standards like SNOMED CT will need to continue to work on ways to comprehensively cover relevant concepts at multiple levels of specificity. While using terminology standards like SNOMED CT helps in the normalization of content and interoperability, additional work will be required to enhance the description logic and develop new definitional attributes used to define SDH concepts. Additionally, the development of SDH-specific domains or reference sets could help users aggregate or group similar content to improve standardization and reduce manual content creation and curation efforts. As a team, we recognize that this is not an easy task for any terminology, but neither is our ability to address social determinants of health within our communities. And with that being said, I'd like to thank you for participating in our session today and hope you enjoy the rest of your time at the Expo.
So can I ask that attendees just give us a moment while we switch over from our pre-recorded content so that Amanda can address some of your questions that you've been submitting whilst we're live. So please note that this session will be available on the event platform for the next 3 months. Thank you. And thank you for that presentation. So we've now got a selection of questions, either from the audience and from myself. So we'll start off one which is coming from the audience, which is a good question to start with, I think. So do you know, you talk about obviously looking through content and there is missing content in SNOMED. Do we know roughly how many concepts we're talking about? How many concepts we need to add to SNOMED to bring it up to social determinants of health standard, if you like?
Oh, wow, that's a really good question. Yeah, I definitely would not have a count. I feel like this is one of those areas that are just forever evolving. So, just trying to define out what really encompasses a social determinant of health. Where does the line between mental health end and social determinants of health begin? Those types of considerations. It makes it really hard to develop an exact count of how many concepts would actually be missing. We know that there's gaps, but sometimes we just don't know until we really start to dig into what's being documented in an EHR or any other type of record, what type of content is missing. Also taking into consideration the area that somebody lives in. If we're looking at the full spectrum of social determinants of health, from the finding of something like food insecurity to educating a patient about the resources available, helping with application assistance, actually making the referral to a support program would really vary a lot from geographical locations. So I really feel like that's a huge question. And there's a lot of terminology coming down the pipeline. We know projects such as the Gravity Project, SNOMED CT, we're always constantly identifying terminology that's needed to capture that, but I would not have a count of concepts.
Well, here's a kind of, so I want to kind of build on this a little with my questions. So you talk about building reference sets in particular areas of social determinants. That obviously includes a number of concepts with different semantic tags. So the obvious difference is findings and procedures. Do you deal with those within a single value set, or do you separate out those value sets so you have the procedure one for economic factors and the findings one for economic factors, or so on?
Yeah, that's a great question. So when we initially started creating these value sets at the time that we sort of launched off this project, um, we definitely chose more granular categories such as food or housing. We did group together any concept that was related to either of those. So that would include all of the semantic tags that we identified in the presentation. Um, Retrospectively, I think that we would have broken those down further to capture those. Whether it was the education piece on programs available versus the referral to a program. We do have the ability systematically within our internal tooling and our internal database to be able to disseminate those. So, if a customer came in specifically wanting something like that, they could either have the entire bucket, so to speak, or we could easily break that out into more specific areas.
So I think a kind of follow-on question, and you kind of highlighted this in one of your earlier comments, is when we talk about social determinants of health, there is no clear distinction between what's clinical and what's social. So there's a lot of gray areas, if you like. Mental health is the obvious one, but it isn't the only one. How do you deal with that gray area, I guess? Do you incorporate that in clinical, or do you drive it from a social end, or is it a combination?
Yeah, I would definitely say it's a combination, and it's also a lot based on possibly your use case. And again, going back to that geographical area, one of the topics, I guess, so to speak, that I have a tendency to struggle with is that mental health piece or abuse. Just as a licensed clinical social worker, um, there's just a lot that goes into abuse and mental health. There are social determinants that drive those. There are mental health and other factors that drive those social determinants of health, right? So they really go hand in hand. It would be hard to really draw that fine line between them. Um, so yeah, it's honestly a true challenge. And I wish that I had the answers, but I would say you really just can't really distinguish where one begins and the other leaves. Identifying at a terminology level is possible, but as far as treating a patient, you know, you you can't ignore any of them, right? So their
Yeah.
medical conditions are just as relevant and feed into their social determinants as it all feeds into their mental health, and the cycle continues.
So one good question from the audience here: We're obviously very focused on SNOMED, and obviously SNOMED is the thing that everybody should be using because it's the global terminology. But in reality, some of the content may be appropriate for other terminologies and standards. Would you comment on that statement?
Yeah, I mean, one of the reasons why we focused on using SNOMED, and obviously for this project specifically, was because of the comprehensive nature. We see a lot more gaps or specific use cases in other terminologies. So, ICD-10 being a billing code system, it has much more of a specific use case for it. So the comprehensive nature of that terminology just wouldn't really capture the full spectrum of social determinants. Um, So we do use map sets to relate SNOMED back to those other terminologies. In our value sets, we have definitely created value sets leveraging LOINC, ICD-10. So SNOMED is not the only value set that we've created, but it by far is the most comprehensive.
Okay, and then I suppose link to the SNOMED side, and in some ways I would say this. So do you find it a challenge to identify, I suppose, missing SNOMED content in some ways that fits into the international release rather than driven by national requirements? Is there any distinction between those two, or is everything international?
I would say that probably a lot of the findings that you would see would be relative to the international releases. I would say when you start to get into program specific terminology, referrals, support, those types of concepts are definitely more driven at a local or a national level than an international level. So even my reference in the presentation to the finding of Meals on Wheels is probably not something that's relative to everybody international, but it is a significant program and support to folks here in the US.
So you mentioned the Gravity project in part of your presentation. SNOMED International has a relationship with the Gravity project. And part of that relationship is identifying new content to be added to the international release. Do you have any additional suggestions of what we could do internationally to make your job easier?
Oh, that's
from a user's perspective.
Yeah, honestly, that's a really great question. Here within the 3M Health Information System, we really are just sort of chipping at the iceberg of what customers are truly wanting to capture. So I feel like at this point, we have the content that most people are looking for, if that makes sense. A lot of the common factors that we're seeing, a lot of the common economic struggles that folks are facing, a lot of the things that came to light, especially during the pandemic, I feel like we do have a lot of coverage there. I feel like there's a lot to be determined in new development, and I do participate in the Gravity project and watch, and I feel like a lot of the content that is coming down the pipeline and in the development stages is only just going to enhance that. So I really do feel like at this point in time, we have a lot of comprehensive coverage for a lot of the information that needs to be captured. I feel like we really need to start capturing that information and encoding that information to truly identify where those gaps are lying, as well as looking at expanding past the EHR. I know that this project specifically was looking at terminology that could be captured in an EHR, but we know that a lot of the information and data around social determinants of health does not exist in the EHR. So being able to expand that into community organizations and encoding that data. And of course, as a licensed clinical social worker, I might be slightly biased to the assessments that we do, but a lot of that information is buried within our assessments. It is definitely something that we look at and attempt to meet those needs for patients.
So I suppose as you touched on that, one of my questions around social determinants, irrespective of your presentation, just a general comment, is the challenge. We obviously focus with SNOMED on implementation in EHRs. The whole area of social care brings in a lot of systems which sit way outside of anything which is clinical, some of which will obviously have computerized systems, other ones which are still paper-based. You're not in a position to give me a definitive answer, but I'm interested in your view. What do you think the challenges are going forwards around implementation to bring all those pieces together?
Yeah, you know, starting with just identifying that that is a need, and I feel like that has already been identified. Um, so people just recognizing that a lot of the data that we need to truly draw this holistic view of a patient really does exist. And so we've already recognized that. Um, I tend to see when we look at how like the NLP or the NLU reasons over documents, that that is all really focused on physician documentation. So starting to recognize that there is other documentation from case managers to social workers, um, nursing, you know, we know how much they do when they and interact with patients. So just making sure that we're pulling in all of the documentation as case managers or social workers, we do all of that care coordination with outside organizations, and a lot of that information is stored in those progress notes, in those assessments, um, conversations that have been taken with that have been had with community organizations. A lot of that really is documented out well, if you have great workers within your organization. So I feel like just making sure that we're pulling in all of what is currently available and then starting to meet the challenges outside of that in the community data, it's going to be a bit more challenging, and I wish I had a better answer for it.
And I have one final question, and I'm just quite interested in your opinion of this, I guess. So one of the things you talk about when you talk about creating value sets is leveraging the hierarchies within SNOMED, and obviously that means leveraging the relationships, the attributes and values within SNOMED. In the area of social care, we don't necessarily have a concept model which supports that content because we've always focused on the clinical side, not the social. Do you see a need to extend the SNOMED concept model with some attributes which would support social care, in addition to adding, obviously, the individual concepts we require?
Yeah, absolutely. And I think that that was one of the areas that really came to light as we started to grab a hold of concepts and started to really dig into what SNOMED does have to offer for our value set creation. We recognize that social needs are difficult to define in general, and to define those on a concept level even becomes more challenging. But I think that as we look back, being able to leverage specific definitional attributes, creating new definitional attributes to really define the hierarchies vary a lot of social information, not all that is relevant to social determinants of health as we know, right? So where is that line? And I would say that creating attributes that really start to define which concepts would be relevant to social determinants of health and which ones are just relevant to social needs and social context in general would make it much easier for a user. It would also allow for us to be able to leverage some of those systematic approaches we have for grabbing that information out of SNOMED and really start to alleviate some of that manual creation and searching for the concepts. Um, but it really is a challenge that I have all the faith that SNOMED, as they start to bring into this new area and shift from just clinical terminology into this more social domain, um, I know that it will come to light, but it is a challenge. Uh, I think attributes would help a lot.
So we're almost out of time. So I'd like to thank you for the challenge of developing the social content area within SNOMED, and thank you for your answers.
Absolutely.
I've enjoyed it. I've enjoyed moderating, and hopefully the audience have enjoyed listening to it. So I'd like to thank you again, and to close this session, and hope the rest of you enjoy the rest of the expo. So thank you.
Wonderful. Thank you, Ian.